Bismillah ar-Rahman ar-Rahim. My name is Thyroid. I am a head and neck surgeon in the Head and Neck and Endocrine Surgery Unit, Faculty of Medicine, University of Alexandria, Egypt. Today, we are going to talk about the thyroid introduction, surgery of the thyroid gland for GP. What a GP must know includes applied anatomy, applied physiology, investigations, and surgical treatment of thyroid diseases. And these include indications, types, complications, and postoperative management. Section 1 will start with applied anatomy. Of course, we are going to tackle certain points as, for example, embryology, anatomical side, blood supply, nerve supply, and others. First, this is a diagram for the embryology of a 4-gestation period, where we can see that the thyroid gland will arise as a primitive bud from the median gut in an area known in the adult life as foramen cecum, or the junction between the anterior 2/3 and posterior third of the tongue. Both sides of the neck, including the 4 branchial arches, we are interested here for the 3rd and 4th branchial arches. The thyroid gland normally starts descending from this area to reside in its in its final destination in the lower part of the front of the neck. And during this descent, it goes down through a duct known as thyroglossal duct, which usually then obliterates and disappears. During its descent, the 4th branchial arch, having an area known as the ultimobranchial body, shares in the histology and development of the thyroid gland. The ultimobranchial body is a group of cells that have migrated from the neural crest and resided here in the 4th branchial arch, gathered together and formed what is known as the ultimobranchial body. These cells, being of neural crest origin, when joining the thyroid gland, will not be under the effect of TSH and will not share in the synthesis of thyroid hormones as the follicles proper of the thyroid gland that is arising from the primitive gut. So these cells become scattered in between the thyroid follicles descending from above downwards, and they are so-called parafollicular cells, or because of their secretion to a certain chemical known as calcitonin, they are called also C cells. Also, we can see that from the 4th branchial arch arises the superior parathyroid gland, while the inferior one arises from the 3rd arch. This means that the superior parathyroid gland will have to travel a shorter distance to reside in its final destination in the neck, while the inferior parathyroid gland arising from the 3rd arch will have to travel a longer distance to reside in the lower part of the neck. That's why the inferior parathyroid gland is more liable to be an ectopic one, because it will travel a longer distance. Also, the combination between the inferior parathyroid gland as well as the thymus means that they will descend together. So sometimes at the root of the neck, this dissociation between the inferior parathyroid gland and the thymus does not happen, and the thymus, as if, drags the inferior parathyroid gland with it into the superior mediastinum, making it ectopic. And this represents the second cause why the inferior parathyroid gland is more vulnerable to be ectopic than the superior one. Also, being inside the thymus in the superior mediastinum is now explained why is it one of the sites where we start looking for a parathyroid gland when it is not there, especially when you are dealing with a case of primary hyperparathyroidism. Okay. When embryology goes wrong, the thyroid gland might not develop from the start. And in this case, there is agenesis and the patient is born cretin without thyroid gland. Another anomaly is that it does not migrate. So the patient presents to us with lingual thyroid. Sometimes part of the gland descends and part resides in the tongue. So patient presenting with lingual thyroid might have a normal thyroid gland in its position and may not. Sometimes it descends partly, while partly It does not. So there is median ectopic thyroid tissue in the neck. Sometimes the thyroglossal duct itself does not obliterate, forming what is known as thyroglossal cyst. Sometimes, most of the times, this thyroglossal cyst contains squamous epithelium, but sometimes it contains also thyroid tissue. So cyst trunk operation should be followed by histopathological examination of the specimen to show whether the thyroglossal cyst is a simple one or it contains some thyroid tissue. And having thyroid tissue, then this thyroid tissue is liable to be toxic in nature, liable to be dormant normal thyroid tissue, and so as well it can be the seat for papillary or follicular thyroid carcinomata, which are both reported to be residing in a thyroglossal cyst. That's why histopathological examination of the specimen following removal of any median neck tissue or of course a thyroglossal cyst through cyst trunk operation should be done. Histopathological examination of such specimen should be done, is a must to be done. Okay, we can proceed then where we can see that the thyroid gland is a butterfly-shaped organ overriding the trachea, arising starting from the oblique line of the thyroid cartilage down to the sixth tracheal ring, where the isthmus overrides the tracheal rings number 2, 3, and 4. Laterally, they abut the carotid sheath. As regards this, we quote this picture from the famous great book of Bailey and Love, where we can see that the arterial supply represents the superior thyroid artery, which is a branch from the external carotid artery, or the inferior thyroid artery, which is a branch from the thyrocervical trunk, first part subclavian. Then the thyroid veins. There is a superior thyroid vein draining into the internal jugular, middle thyroid vein, if present, draining into the middle, into the internal jugular vein, and the inferior thyroid vein or veins draining into the left innominate vein. This picture shows that the inferior thyroid artery gives the blood supply for both the thyroid lobe as well as the ipsilateral two parathyroid glands. It also shows that we can devascularize the thyroid lobe by ligating the branches of the inferior thyroid artery going into the lobe while preserving the trunk so that we can preserve the blood supply to the parathyroid glands. And in the very same plane where we devascularize the thyroid lobe, we can and we will find the recurrent laryngeal nerve so that we can preserve it during the operation of thyroidectomy. Here we can see that this is the thyroid lobe, this is the cricothyroid muscle, this is the carotid sheath, and this is the vagus nerve from which a superior laryngeal nerve arises, and this superior laryngeal nerve divides into internal laryngeal that goes into the inside of the larynx to be sensory to the interior of the larynx down to the level of the vocal folds, and an external one which is known as the external laryngeal nerve that supplies the cricothyroid muscle, which is the only intrinsic laryngeal muscle residing outside the laryngeal box, as well as it is the sole tensor of the vocal fold, and it is the only intrinsic laryngeal muscle that is not supplied by the recurrent laryngeal nerve. And as we can see, the external laryngeal nerve is in close relation to the superior thyroid vessels. This is a picture quoted from Stella Moran textbook of head and neck surgery, where we can identify the Joll's triangle. The Joll's triangle is the triangle in which the superior and the external laryngeal nerve resides. This is another picture quoted as well from Stella Moran textbook of surgery, where we can see that the recurrent laryngeal nerve resides in what is known as the Beer's triangle. The recurrent laryngeal nerve normally resides in the Beer's triangle in the tracheoesophageal groove, and it passes deep to the vessels of the inferior thyroid artery and then deep to the Barry's ligament to enter the larynx under cover of the inferior constrictors as well as the cricothyroid muscle. Sometimes there is what is known as Zuckerkandel nodule, which might push the recurrent laryngeal nerve beneath it or hide it between the body of this Zuckerkandel nodule and the trachea, making its dissection more and more difficult. Another anomaly is that the recurrent laryngeal nerve passes in between the branches of the inferior thyroid artery, not deep to them, not superficial to them as rarely happens, but in between the branches, which makes it much more vulnerable to be injured while ligating these vessels. In a very minority of patients, about 2%, especially on the right, only on the right side, we can have a non-recurrent laryngeal nerve. And as we can see, the recurrent laryngeal nerve is the equivalent of the superior laryngeal nerve, and that's why it is sometimes called the inferior laryngeal nerve, because it carries the rest of the work not done by the superior laryngeal nerve. It supplies, the recurrent laryngeal nerve or the inferior laryngeal nerve, it supplies sensory to the interior of the larynx from the level of the vocal folds and downwards, as well as it supplies motor for the rest of the intrinsic laryngeal muscles, that is, all the intrinsic laryngeal muscles except the cricothyroid. As regards the muscle, what are the intrinsic laryngeal muscles? The intrinsic laryngeal muscles are defined as the muscles that are responsible for mobility of the vocal folds. These are adductors and abductors, and as we said, they are all supplied by the recurrent laryngeal nerve, the tensor, which is a single one called cricothyroid, supplied by the external laryngeal branch, external laryngeal nerve, and their action is the mobility of the vocal folds. Extrinsic or strap muscles, these are the muscles that are responsible for the mobility of the vocal folds. They are in two strata, a superficial one, which is the longer one, called omohyoid and sternohyoid, then an inner, deeper one, which is shorter, known as sternothyroid and thyrohyoid. And as we can see, the four muscles, as most of the structures of the neck, are named from down upwards. These muscles are supplied by the ansa cervicalis, and they are responsible for mobility of the larynx as a whole. So we have till now gone through the embryology, anatomical side, blood supply, nerve supply, muscles, and important structures related to the glands. The next step is to have an idea about the lymphatic drainage. Of course, the very famous classification of cervical lymph nodes of the Memorial Sloan Kettering Cancer Center of New York is well known to everybody, where the lymph nodes of the neck are divided into 6 levels, as well as the 7th one, which is present in the superior mediastinum. So blood supply of the thyroid gland goes to areas or levels 6 and 7, which are the first acrine lymph nodes, and then they go to level 3, then 4, then 5, then 2, then 1. This is a sketch animation, simple animation, showing this is level 1, then 2, 3, 4, level 5, level 6, and this is level 7. As regards the deep fascia of the neck, it is unique in that it is 3 deep fascias. There is one which is called the investing layer of the deep fascia of the neck, which surrounds the whole muscles of the neck, and another one which is called pretracheal fascia, and a third one which is called the prevertebral fascia. The Barry's ligament is the posteromedial condensation of the pretracheal fascia, which anchors the thyroid lobe to the lateral edge of the trachea and hides the recurrent laryngeal nerve just behind it. The last item for the section of anatomy is the histology, where the thyroid gland is formed of thyroid follicles filled with colloid or thyroglobulin, thyroid hormones in combination with the protein of globulin, inside the follicle, which is lined around by follicular cells that have the capability of doing many chemical steps, as we will see in a minute. And in between the follicles, there are the lymphocytes, the blood vessels, the parafollicular C cells, and septi from the thyroid capsule, dividing the thyroid gland into lobes and lobules. Again, these are the items that have been tackled in the section of anatomy. Section 2 is the applied physiology. As we all know that the thyroid gland is an endocrine gland under the control of the posterior pituitary through the famous chemical, which is known as the thyroid stimulating hormone, which in turn is under the effect of thyrotropin releasing hormone from the hypothalamus. And the thyroid gland, under the control of these two substances, secretes what is known as T3 and T4 into the blood, where they act on the target organs, as well as they have a feedback inhibition or stimulation of the TSH and TRH. So it's a simple endocrine axis where the hypothalamus affects the posterior pituitary to release the TSH, and the posterior pituitary controls the thyroid glands through the release of the TSH to control its blood supply, its size, its degree of metabolic activity, so that T3 and T4 needed by the body are secreted by the gland. As we can see, the iodine present in our food is taken into the inside of the follicle, where it is changed from iodide salt into iodine, and this iodine is organified by combining to tyrosine to form monoiodo and diiodotyrosine. Through a coupling process, they then form the T3 and T4 through the coupling of one molecule of monoiodotyrosine and one of diiodotyrosine to form T3, or two molecules of diiodotyrosine to form T4. These soon bind with globulin inside the follicle to form the thyroglobulin or the colloid material, and when the body needs them, through a process of proteolysis, the protease enzyme splits them again so that T3 and T4 are freed into the blood, and when they are in the blood, they again combine with thyroglobulins and prealbumin, to globulins and prealbumins, to form plasma protein attached hormones, while a very, very small amount, about 1% or less, remain free, and these are the hormones that are responsible for the metabolic activity, known as free T3 and free T4. Here we can just notice that the process of proteolysis is inhibited by much iodine and by lithium. This information is very important physiologically for us, because the large amounts of iodine can block the proteolysis and inhibit the T3 and T4 production of the gland, while the iodine itself is the raw material from which the thyroid hormones are synthesized. So this is important, and a very clear example that we can use Lugel's iodine in large amounts till now to control patients with Graves' disease before surgery. The second material, which is lithium. Lithium is present in many antidepressants and mood stabilizing agents, which are by default taken for long periods of time. So lithium can induce proteolysis, decreasing the free T3 and free T4 in the body, resulting into an elevated TSH and a goiter, which can present clinically and mismanaged or misdiagnosed. So in such a case, we have to know that the role of lithium should be stopped, so that the thyroid gland might again involute to its normal size. The differences between FT3 and FT4 are well known. The production of the thyroid gland is mainly FT4, about 90%, while only 10% are of FT3. 0.3% of this total T3 forms the free one, while 0.03% of the total T4 represents the FT4. The FT3 is 4 times more potent than the FT4 but its onset of action is for after a few hours and lasts for 48 hours only, while FT4 starts action after a few days and lasts for a month. The next section is section 3, or that of investigations, and these include, number 1, the thyroid function tests, which are TSH, FT3, FT4, and we have to know, and this is a quote from Bailey and Love, that assays of total hormone for both are now obsolete because of the confounding effect of circulating protein concentrations, influenced by the level of circulating estrogen and nutritional state. So we have to measure the FT4 and FT3 together with the TSH. This is a table showing very clear idea about what an endocrine axis means. When the patient is euthyroid, his TSH will be normal and his FT4 and FT3 are normal. When he is thyrotoxic, the TSH is undetectable and both hormones are high. If he is myxedematous, the TSH is high while the FT4 and FT3 are low. When he is receiving suppressive T4 therapy, he will have his TSH very low and the FT4 and FT3 still high. And in a unique entity known as T3 toxicity, the TSH will be low or undetectable. The FT4 is normal, but the FT3 is the one which is high. So these are the tests that we do for thyroid function tests, in addition to anti-thyroglobulin antibodies and anti-peroxidase antibodies, which are elevated in a mild fashion in most of the thyroid diseases, but they are still higher in Hashimoto thyroiditis, especially the anti-peroxidase antibodies, and it helps in the diagnosis of Hashimoto thyroiditis. However, another quote from Bailey and Love, short practice of surgery, can let us know that there is also a seronegative thyroiditis, which means that the thyroid, the antibodies might be normal while the patient still can be diagnosed as Hashimoto. Recently, there is the TRAB, or the TSH receptor antibodies, and this is very important in the differentiation between Graves' disease and Hashimoto thyroiditis. The second item for the investigations is the imaging, where we can have a plain X-ray for the neck or chest, barium swallow, ultrasound neck, CT neck, MRI neck, or others. However, the ultrasound neck is the most important and useful and informative tool of investigations. Third, we have the radioisotopes, where we do thyroid scanning or whole body scan using either iodine 123 or technetium-99. The iodine 131 is only used for therapeutic uses. It's very poor diagnostic tool. So iodine 131 is reserved for treatment, as we will see in a minute, while iodine 123 and technetium are the best for diagnosis, for doing a thyroid scan or a whole body scan, where we search for a cold nodule. This lost interest in the preoperative diagnosis of malignancy now. However, it has a very important role in the management and in the follow-up of patients with cancer, as we will see in a minute. The fourth investigation we have to know is the biopsy. The fine needle aspiration cytology of a thyroid nodule, especially if ultrasound guided, is extremely useful and should be done according to the recent thyroid classification versus the size of the nodule, so that we can take, or the sonographer can simply take a decision of either follow the patient up or have a fine needle taken. Laryngoscopy is important to determine the mobility of the vocal folds, especially preoperatively. So we can summarize the routine investigations that should be done for every thyroid patient as TSH, FT3, and FT4, thyroid autoantibodies, ultrasound plus or minus fine needle aspiration cytology as seen by the sonographer. However, others might be tailored according to each case. Other investigations can be tailored according to each case. The last section of our talk today is the surgical treatment of thyroid diseases. Of course, this is known as a thyroidectomy operation. The indications of thyroidectomy are either cosmesis, compression, which means dyspnea or dysphagia, or complications. Complications include hemorrhage, retrosternal extension, and cancer or its suspicion. Of course, the complications also include the toxicity. When the patient has toxic goiter, surgery might be one of the tools that we can use for his treatment. The types of thyroidectomy as regards the extent, we have total thyroidectomy, where we remove both lobes of the thyroid gland, isthmus and pyramidal lobe. Near total thyroidectomy, where we leave a remnant on one side and remove the rest of this lobe, the isthmus, the pyramidal lobe, and the whole of the other lobe. And of course, this is not an office decision. It's an intraoperative decision that we have to make when there is extreme difficulty in removing this part of the gland that is left. And it should be very small, so that if the patient is a cancer patient, this does not represent recurrence and can be ablated by radioactive iodine then. Hemithyroidectomy is the second operation that can be done and taken for a decision as an office decision, where we remove in the hemithyroidectomy the lobe, the isthmus, and the pyramidal lobe, leaving the other lobe completely non-touched, so that the planes remain virgin, so that if this patient needs another operation in the future, the planes are not distorted and the anatomy will be preserved, so that the operation carries no further risk. Isthmectomy is the operation in which we remove the isthmus, either in anaplastic or any undifferentiated tumor of the thyroid gland, or aggressive one where with the patient the tumor is irresectable. We can only remove the isthmus so that we can insert a tracheostomy tube and to relieve the compression manifestations of such an aggressive anaplastic carcinoma, for example. And the other indication, whenever there is a single nodule, which can be removed only with the isthmus, while both thyroid lobes are morphologically normal and the laboratory functions indicate that they are functioning well, so that we can remove this nodule through the isthmus, together with the isthmus only, leaving both lobes of the gland functioning normally. As regards types of thyroidectomy, as from the when type of view, when do we do thyroidectomy? We can do elective thyroidectomy, and this is done, of course, as its name applies, for diseases that have been diagnosed and necessitates the removal of the thyroid gland. So we determine the time for removing a diseased thyroid gland, whatever the disease is. Prophylactic thyroidectomy is done in cases of men syndromes, types 2A and 2B, when the patient has a positive mutation of the red proto-oncogene, meaning that the patient will have medullary carcinoma one day. So we remove the thyroid gland before developing this tumor. Incidental thyroidectomy means removing the thyroid gland or one of its lobes together in the part of another operation. Sometimes a pharyngeal or esophageal cancer or a parathyroid cancer is invading the thyroid lobe, so that it has to be removed together with the other operation, or in the rare instances of the fourth branchial arch fistula, where the fistula passes through the thyroid lobe. So together with the fistula operation, the ipsilateral thyroid lobe, which is usually the left one, should be removed together with it. Emergency thyroidectomy is only done when the patient starts to bleed in his nodule or as a result of a fine needle. It's a very rare situation, but it happens. So emergency thyroidectomy should be done quickly, because the patient will be developing a hematoma in a thyroid nodule or inside the thyroid capsule, which results into his suffocation. Early complications of thyroidectomy include stridor, and this might be caused by recurrent laryngeal nerve damage, laryngeal edema, laryngeal spasm, tracheomalacia. The other one is hematoma, tracheal injury, esophageal injury, thyroid crisis, vomit aspiration, pain, and dysphagia. These are the early complications that might occur following a thyroidectomy. Delayed one include hematoma still, seroma, infection, hypocalcemia, ugly scar, and voice changes together with stridor. Again, it can occur as a delayed complication after a few days due to what is known as delayed recurrent laryngeal nerve injury, which is most probably due to its ischemia. Postoperative management includes the following. Postoperative days, how many days should the patient stay in hospital? Of course, this differs in different medical schools. However, it is usually done between 1 to 2 days following the operation, which means that I completely refuse that the patient doing thyroid surgery is to be discharged on the same day. Thyroid surgery, in my humble opinion, can never be a one-day surgery, never. So the patient has to stay overnight in the hospital, at least for one night following the surgery, if not 2. The hospital medications, I do not include antibiotics in my hospital medications because thyroidectomy is a type 1 operation. It's a clean operation, except of course if the patient has another risk factor as chest infection, diabetes. The thyroidectomy has been combined with a modified radical neck dissection so that it's a very lengthy procedure. So in such cases, we can have antibiotic. Other than that, the patient only receives painkillers, fluids as necessary, any medications of his associated chronic diseases as diabetes or hypertension or something like that. I start oral calcium 48 hours after the surgery, as we will see in a minute. When do we remove the drain? Usually between 24 and 72 hours. The take-home medications are still a painkiller, anti-edematous element, and I give a compound of calcium together with vitamin D for about maybe 1 month, so that prophylactically, so that the patient won't suffer from any numbness or something like that. The post-operative instructions include that the patient has no restrictions in his food or drinks or sleep or any daily usual activity. Stitch removal usually is done between 5 and 7 days post-operatively. The scar medications are still of importance to get a better scar. Then the follow-up regimen for non-neoplastic goiters include: must we give replacement therapy? Following hemithyroidectomy, we should not give. After total thyroidectomy, yes, we must give replacement therapy. When to start replacement therapy? Due to the absence of thyrogen in Egypt and in many countries, I do not start replacement therapy after the operation, but I withhold thyroxine after surgery until the histopathology report is issued, so that if the patient does not need iodine, he will start therapy. If he needs iodine, then we will complete his withholding of eltroxin for another week or 10 days until his TSH exceeds 30, and then we start replacement after the whole body scan done 5 days after the radioactive iodine. I know that in other places, when thyrogen is available, replacement therapy is started immediately after surgery. How much to replace? It's well known to be about 1.6 to 1.7 microgram per kilograms. So we start with the empirical dose. How frequent to check the hormonal blood levels? I do this for the first time 6 weeks after start of replacement therapy, and then when the dose is well adjusted, I do the hormones every 6 months to 1 year as a follow-up. What parameters to check? I usually check the TSH as well as the FT4 together every time. Follow-up regimen for neoplastic goiters, we do the thyroid hormones in addition to thyroid tumor markers. If the patient has a differentiated thyroid cancer, we do thyroglobulin and anti-thyroglobulin antibodies. If the patient has medullary carcinoma, we check for calcitonin and carcinoembryonic antigen. Neck ultrasound can be done for neoplastic goiters every now and then, according to your necessity. And this concludes our talk today. Thank you very much. And this is my email. If any questions are there, you can send them to me on this email, and I will be very happy to reply to them. Thank you very much for watching my video, and please feel free to ask me about anything that you need to ask. Thank you again, and see you in another videos. Bye.